Neurology Quiz number 93. Describe the clinical features, pathophysiology, and treatment of complex regional pain syndrome, or CRPS. CRPS is a chronic neuropathic pain disorder that has characteristic clinical features including allodynia, hyperalgesia, pseudomotor and vasomotor abnormalities, as well as trophic changes. It is of two types. Type 1 was previously called reflex sympathetic dystrophy and occurs in the absence of nerve trauma. Type 2 was previously called causalgia and occurs in the presence of established nerve trauma. Clinical features are similar in the two types. CRPS is more common in women. In most cases occur in the fifth decade. Although it can occur anywhere in the body, CRPS usually affects an arm and hand or leg and foot. Predisposing factors for CRPS include fractures, especially of the wrist, trauma, ligament or tissue injury such as sprains, surgery or stroke. CRPS type 2 is related to injury to specific nerves. Clinical features: number 1, pain, unprovoked or sudden severe pain that can be constant or worsens with activity. Pain is reported as burning or squeezing or pins and needles sensation. With time, pain can spread to involve the entire arm or leg. Rarely, mirror pain may occur at a matching site on the opposite limb. Pain is associated with allodynia. Usually, non-painful stimuli cause pain. This causes the skin of the affected limb to be painful to light touch or to physical contact, as well as hyperalgesia. Usually, painful stimuli cause exaggerated pain, and patients can notice severe or long-lasting pain after mildly painful stimulus such as pinprick. Number 2, autonomic dysfunction. Vasomotor changes include changes in temperature, and the affected limb may be warmer or cooler than the opposite side, and the skin may show color changes with blue or red discoloration or a blotchy pattern due to changes in blood flow. In addition, there is swelling of the affected area. Pseudomotor dysfunction can cause patches of profuse sweating or no sweating. In addition, there may be overgrowth of hair and nails or lack of growth. Number 3, other features. Patients may report weakness in the affected limb, and other motor features include tremor or dystonic posturing. Also seen is joint stiffness and reduced range of motion of the joints. There is thinning of bones, which can be detected on bone scans and x-rays. This figure summarizes the major features of complex regional pain syndrome, which include pain and increased pain sensitivity, changes in skin color and texture, changes in skin temperature, swelling, decreased function, and rapid or no hair and nail growth. These figures show patients with CRPS with a red and swollen foot on the left side and a foot with bluish discoloration and dystonic posturing on the right side. These figures from patients with CRPS show a swollen and erythematous hand and arm on the left side and mottling of the skin on the right side. Course can be acute or chronic, which is more than 3 months duration. Recent studies indicate that while pain and disability improve with time, most patients have some degree of pain after 1 year. Severe or chronic cases are disabling and can prevent a person from working or carrying out activities of daily living. CRPS is associated with depression and anxiety and decreased quality of life. Factors that adversely affect recovery include underlying diabetes and smoking. Investigations: EMG and nerve conduction study can show evidence of nerve injury in CRPS type 2. MRI, ultrasound, and other imaging modalities may show evidence of underlying nerve and tissue damage. X-rays of the feet or hands show demineralization of bones. Triple phase bone scans may demonstrate changes in underlying bones. This is an X-ray of the foot showing demineralization of bone in CRPS, which is related to decreased microcirculation. This is most prominent at the ends of the bones. Diagnosis: the diagnosis of CRPS is based on the characteristic clinical picture. The Budapest criteria are currently the most accepted method for diagnosis. In brief, these criteria are as follows. Number 1, there should be continuing pain disproportionate to any inciting event. Number 2, a patient must report at least one symptom in 3 of the following categories. And number 3, the patient must have at least one sign at the time of evaluation in 2 or more of the following categories. And number 4, there should be no other diagnosis that can explain the signs and symptoms. Pathogenesis. A summary of pathogenesis of CRPS is as follows. The original injury leads to central and peripheral sensitization. Pain impulses in the brain trigger impulses in the sympathetic nervous system. This leads to an inflammatory response in the blood vessels, which in turn causes swelling and increased pain. The worsening pain triggers a similar cycle, establishing a cycle of pain, swelling, color changes, etc. Treatment. Treatment should be instituted early, as delay may lead to an unfavorable outcome. Early CRPS is less resistant to treatment and has a better prognosis. The goal of treatment is to improve pain and discomfort as well as to restore function and prevent disability. The various modalities of treatment are physical and occupational therapy. Manual therapy and exercise improve range of motion, pain and function, and reduce disability. Other therapy modalities include mirror therapy, transcutaneous electrical nerve stimulation, ultrasound, etc. Medications. NSAIDs and corticosteroids have been used in CRPS, as inflammation is thought to play a role in the pathogenesis. Although some studies have found that corticosteroids improve pain scores, other studies have noted no significant difference. Anticonvulsants and antidepressants. Gabapentin is the most widely studied medication. Despite its widespread use, there is no reliable data that it is consistently effective. Other medications used have included amitriptyline, duloxetine, and pregabalin. Biphosphonates. These medications inhibit osteoclastic activity. Some reports suggest that these drugs reduce pain in CRPS type 1, especially in those with concomitant osteopenia or osteoporosis. Opioids. Opioids have been used in severe cases, but no data is available to support their use. NMDA antagonist. Medications like ketamine have been hypothesized to reverse central sensitization in CRPS. Low-quality evidence suggests that IV ketamine may improve pain in CRPS for several weeks. Behavioral therapy. Behavioral therapy is recommended as part of comprehensive treatment, despite lack of clear evidence. Interventional treatment. Sympathetic blocks. As sympathetic hyperactivity is thought to exist in CRPS, lumbar sympathetic nerve blocks are used to treat lower extremity symptoms, and stellate ganglion blocks are used for management of upper extremity symptoms. However, because of a paucity of evidence, no definite conclusions can be drawn on the efficacy of such treatment. Spinal cord stimulation. This has been used in cases with resistant pain. Some studies have shown that spinal cord stimulation improves pain scores and quality of life in CRPS. Dorsal root ganglion or DRG stimulation. DRG stimulation was approved by the FDA for treatment of lower extremity pain in CRPS. One multi-center study found that DRG stimulation was more effective than spinal cord stimulation in reducing pain and improving quality of life.